Yeah, beautiful. There it is. Okay. All right. Well, thank you so much for joining us this evening. My name is Krista Becerra, and my co-presenter here is Dr. Resa Gardner, and we've got Kimmy Herrera hosting for us so that if you have questions in the chat, she makes sure they let us know. We're going to hold off on questions till the end, and we'll have probably 15 minutes or so to answer everything for you. We wanted to bring everybody together to listen to this presentation in an effort to open up more connections in our community and invite more collaboration. Dr. Resa and I met as affiliates of the Breathe Institute, which we'll discuss a little bit more. And our practices are both on the Front Range of Colorado, and we're separated by distance, but not by philosophy. So we wanted to create a common thread across the Front Range to find providers who want to help us help people improve their overall health. A little about me. I own a practice on Pearl Street in Boulder that I've owned for about 4 years. I'm a Colorado native, born and raised in Denver, where my family still lives, and I currently live in the mountains of Nederland, just up the canyon from my office. I graduated from University of Colorado Dental School in 2015 and completed a general practice residency there. And then I became an affiliate with the Breathe Institute to study under Dr. Surush Zaghi last year. I've got a passion for airway breathing and the impact of tongue ties, and I've spent a lot of time the past 5 or 6 years learning about it. And I've learned enough that a heavy focus of my practice is now on sleep dentistry, facial pain, TMD, myofunctional therapy, and tongue ties. And I've really been enjoying lately meeting and collaborating with all the non-dental professionals in our community. So we really wanted to gather some of the non-dentals and see if we could get a bigger network going. Oop, yep, sorry, go ahead.
All right, everybody. My name is Dr. Resa Gardner, and I also am a Colorado native. And I want to thank you all for joining us today. I received my dental training at the School of Dental Medicine here in Colorado, after which I completed a residency in general dentistry, and I've been practicing for the last 11 years. As mentioned, I completed the Breathe Affiliate program, where I received one-on-one training with Dr. Zaghi. He came out to Colorado last spring and proctored my surgeries and provided guidance on endpoints for releases and mastering surgical technique. And so the Breathe Institute is really where Dr. Krista and I got connected. So proper airway development starts very early on in infancy and continues through childhood. And I started Untied Colorado to focus on proper orofacial development with a focus on the airway development. So I treat an even mix of patients ranging from infants who are having trouble nursing to young children all the way through to adults. And we utilize a comprehensive approach, often using CBCT on kids and adults to look at the skeletal development to guide us in our decision-making. And so we look at the whole picture, both Krista and I do, and then decide on the best route and order of treatment for our patients. So if the oral cavity and midface develop properly, then we can mitigate a whole host of issues later on in life, such as sleep breathing disorders, cardiac disease, metabolic disease, dental disease, etc. So Untied was really founded to facilitate an interdisciplinary approach to treating the upper airway complex. And that's why I'm so glad all of you are tuning in today. There is really so much to be learned from each other. So there's all this talk about airway and expansion and tongue tie, and in the dental world, tongue tie is a very controversial thing. So one thing that I want to encourage us and keep in mind today is not whether you're right or wrong or know more than someone or better than someone else, but I really want us to focus on what is our responsibility as healthcare providers. And so I want to start our presentation off with this quote that Dr. Zaghi famously starts all of his lectures with to set the stage. And it says, "Half of what you learn in medical school will be shown to be either dead wrong or out of date within 5 years of graduation. And the trouble is no one can tell you which half. So the most important thing to learn is how to learn on your own." And asked Dr. Zaghi during my time with him in LA was that if tongue ties, tongue posture, were even taught, considered in medical school or ENT residency or in his sleep fellowship program. And he said, no, it was never taught. He'd never received any education on it. And so his answer right there demonstrates the purpose of continuing education. And this quote right here, it's no different for any of us in our respective health professions. And so I just really want to thank you and have so much respect for all of you for taking the time out of your busy day to join us and learn more together. So Dr. Krista and I completed our affiliate programs and training with Dr. Zaghi, as mentioned. And the next slide is just showing, pictures of us with our teams out in LA with Dr. Zaghi. Yep, there it is. Super great experience.
Nice.
Learned a lot.
There you go.
Yep. Okay. All right. So much of the work that Dr. Krista and I do is centered around tongue ties, but we do so much more than that. We address the whole picture, as I mentioned before, which is why we'll be showing you guys some of the adjacent subjects and the information that has stuck with us the most that we feel impacts our patients from all walks of life. Okay. So we're going to present some updates in the research that connects the dots with tongue ties, airway, posture, and overall health. And I'm going to start my part with presenting facial development and the role that proper tongue posture plays in that. This lecture tonight is only going to be about 45 minutes in length, but we encourage you guys to reach out with questions or cases you have questions on, and Kimmy will help moderate that, and we'll try and get to all of them at the end. So let's dive into the information. This slide, this next slide here demonstrates how development is affected, and it really simplifies a very complex cycle. So if you start with a restricted tongue mobility, then you're going to have low resting tongue posture, which is going to be the equivalent of mouth breathing or lead to mouth breathing, which then in early development, you get abnormal oral facial growth, which leads to limited tongue space because the jaws don't develop properly, which leads to dysfunctional oral myofacial compensations, which a lot of our myofunctional therapists and body workers are very familiar with. So your tongue posture really affects your ability to breathe through your nose. And so the whole basis of this is proper nasal breathing. So let's look at the function of the nose. It humidifies the air. It acts as a natural filter, which reduces inflammation. It promotes the activity of the parasympathetic nervous system. It slows your breathing and your heart rate, which then allows your lungs to efficiently exchange and balance oxygen and carbon dioxide, so your muscles and brain can function better. It also enables the release of nitric oxide, which is a gas produced by the body, and the primary role of it is for vasodilation. This allows more blood, oxygen, and nutrients to flow through the body and nourish vital organs. So signs of nitric oxide deficiency include low stamina, blood pressure concerns, sleep issues, brain fog, and hormone imbalance. Now let's look at how we breathe through our nose. So here is what the nasal breathing route requires. It requires one, a patent nasal passage. The nasal passage has to be open. And it also requires posterior tongue elevation. So the contact of the tongue to the roof of the mouth creates a negative pressure that pulls the soft palate down and forward to allow airflow through the nose, as seen on the picture on the left. So when the tongue posture is low during nasal breathing, the soft palate can be pulled back into the airway that you can see on the right side, on the right hand. So it's much similar, like when I go over this paper, the paper is pulled towards the airflow. The airflow from the nasal passage passes back behind the soft palate. The soft palate is pulled back and it obstructs or partially obstructs the postnasal passage, as can be seen on the photo on the right. And this happens especially while you're sleeping. Okay, so I want you to think of your tongue as the on-off switch for nasal breathing. So if all of you are just sitting there now with your mouths closed, breathe through your nose, take a couple of deep breaths, and I want you to notice where your tongue is. It's likely on the roof of your mouth. So now I want you to, still breathing through your nose, bring your tongue down, try to keep it on the floor of your mouth, and notice how different and odd that feels. So our tongue needs to be elevated for proper nasal breathing, and we should be obligate nasal breathers unless we're running and exerting ourselves heavily. And this is why it is so critical early in childhood to not have mouth breathers, even if their mouth is just partially open, because during development, our bones are softer and malleable, and that light pressure of the tongue on the roof of the mouth during nasal breathing is your natural palatal expander in infancy, starting as early as infancy, all the way through early childhood. So if an infant or child has low tongue posture, meaning they're a mouth breather, again, even if the mouth is just partially open, it's going to change greatly the trajectory of their skeletal growth. So we can switch to the next slide. Is it switching? There it is. Okay, so the roof of the mouth, oh no, go back one, Krista. There you go. The roof of the mouth is the floor of the nose. So if our tongue is our natural palatal expander during development, it is also expanding the floor of the nose. So the tongue posture effectively develops the mid-face right here, and therefore effectively the airway. If your palate doesn't develop wide and broad, neither does your nasal passage. It's going to develop narrow as well. And this leads to common problems in the nose like deviated septums and easily collapsible nares, both of which make nasal breathing extremely difficult. So mouth breathing is bad news. Let's take a look at the anatomy. So the upper jaw, called the maxilla, has a left and a right side that fuse together down the middle. And you can see the one side outlined in pink on the right-hand picture. So the maxilla is going to form the roof of the mouth, the floor of the nose, and part of the floor of the orbit. So essentially, like I mentioned, it makes up your mid-face right here. So as you have good tongue posture and nasal breathing during development, you are naturally expanding your maxilla. And you can see this outlined with the red arrows. What I mean by expansion, you're expanding it outwards. So it's not just about expanding your palate to create space for your tongue and your teeth. It's also about expanding your palate to create a wider nasal passage as well. So maxillary development is super important in the transverse, meaning side to side, AP direction. So it grows forward, and then vertical, it grows down. The maxilla grows out, forward, and down. And it is the diagnostic arch in the airway, in airway health. So there was a 2002 study that found that moderate to severe sleep breathing disorders increased 3 to 7 times when they had a deficient maxillary growth. So the deficient maxilla means that the soft palate is further back towards the pharyngeal wall, meaning the maxilla did not grow forward. If you want to flip to the next slide really quick, Krista, just so we can see that. So the soft palate, meaning that little soft tissue back there, if the maxilla doesn't grow forward, that soft palate is going to sit further back. All right, we can switch back to the previous one. Okay, so we need the maxilla to grow in all 3 directions. And as you can see down the middle of the roof of the mouth, there's a suture where the left and the right side meet and they intertwine. And this suture interweaves throughout the development so that by your early teenage years, usually around 13 years old, conventional orthodontic expanders will not open and expand that suture anymore. And you will mostly just get tipping of the teeth. And I often get the question, when do we need to get kids in for an orthodontic consultation? And I would say as early as 4 to 5 years old. If they have a narrow maxilla or sleep breathing issues that you're concerned about, get them in that early. Dr. Krista will go over a screening tool that we use to help screen for sleep breathing disorders. I would recommend doing a consultation with an orthodontist that is educated in airway development, because not all are trained the same. A lot of this literature that we're presenting has not made it into specialty training institutions. And so, yeah, if you have trouble finding someone, feel free to reach out to Dr. Krista and I, and we can help you find someone in your area. Okay. to one more, Krista. Okay.
Maxillary
So if
deficiency.
you haven't spent a lot of time looking in mouths, yep, that's perfect. If you haven't spent a lot of time looking in mouths, here's a visual of what we talk about, or what we mean by a narrow versus a broad, wide maxilla. So the picture on the left shows a narrow maxilla. The one on the right shows a nice, broad, very well-developed maxilla. The one on the left, you're going to have less tongue space for the tongue. The one on the right, plenty of space for the tongue, and also a bigger nasal passage. So again, low tongue posture leads to a narrower upper arch development. Good tongue posture during early development gives you more tongue space and you get a broader arch and broader nasal passage. Okay, so now we've talked about the upper arch. Let's just take a brief look at the lower arch and show how it grows. It grows basically up and back. And as it does, it pushes the body of the mandible down and forward. People always ask, I get the question often like, well, you're expanding the upper arch. Can you expand the lower arch? Really effectively, you can't really expand the jaw itself. But a lot of times if the upper arch is narrow, those bottom teeth on the lower arch are tipped in. And so when we talk about lower arch expansion, really what we're doing is we're just uprighting those teeth and giving the tongue more space there as well. Okay. In mouth breathers, the trajectory of the growth is changed to a clockwise directional growth. So if you look at the picture on the left, that is the proper facial development. You get the tongue posture forward. It helps push the maxilla forward. The maxilla still grows down a little bit, but as long as you have good tongue posture, it's not going to overgrow down. In mouth breathers, the jaw is slightly open, so then the upper jaw starts growing too far vertically down, and you end up with a longer face and end up also oftentimes with an open bite. And a lot of times, more often, you'll see gummy smiles in these patients because, again, as the mandible grows down and back, the maxilla just keeps growing vertically down. And you get what's called vertical maxillary excess, or VME, which is often observed by the lay person as a gummy smile. So here's a picture of what that looks like. So diagnosing VME usually requires an analysis of a cephalometric X-ray. Orthodontists take these types of X-rays pretty routinely. And it's important to know that some people have gummy smiles for other reasons. So, I mean, if you see someone walking around with a gummy smile, don't accuse them of being a mouth breather, because there are other things that cause gummy smiles. All right, so chronic mouth breathing can alter facial development, which we just saw, leading to a long, narrow face. And you also tend to see poor forward head posture, as this posture, leaning forward like this, by the picture on the far right, helps open up the airway and helps them breathe better. And forward head posture can lead to muscle tension, headaches, etc., as many of you myofunctional therapists and body workers are well aware of, and general dentists as well. We all know that forward head posture can lead to a whole host of things. Okay, so this paper right here is published by Dr. Yoon. She's an orthodontist who is really big into the airway development research. And she and Dr. Zaghi and others worked on this paper. And it really is a great paper to read that gives a roadmap of what is happening at given times during growth and when to intervene and what types of interventions are indicated in the developing child to help them grow healthy faces. And I can send the link in the chat for this paper as well. It's an excellent read and definitely worthwhile reading. I also want you to note that this paper was published in 2023. So a lot of this literature is newer, like in the last 8 years or so. And so it's not really caught up with institutions. So you need to give your orthodontists, dentists, primary physicians, and ENTs a break if they don't understand the airway development portion as a reason for early treatment in kids. But again, seek second opinions with providers that have a background in airway development. And you can always reach out to me or Dr. Krista for providers, again, that we know are in your area. Really quick, we talked about expansion, using the tongue as the primary natural expander early on in infancy and early childhood. But if the arch is not developing correctly, then what we use is called a maxillary palatal expander. Really 0 to like 4 years old, keep a removable expander. So this picture isn't really a great representation. On our left. Oh, we lost the picture, Krista. Go back one. There it is. Okay. So the palatal expander, we use like a fixed one that's attached to the teeth, as you can see in the picture, the yellow picture there. And basically you turn the screw in the middle and it just helps open up that mid suture and get true palatal expansion there. Again, by the time they're, around 13 years and up in general, that tooth-borne expander is not going to expand the palate effectively, and you'll get tipping of the teeth. So then what we use is called mini implants in the roof of the mouth. They're just a few screws on the roof of the mouth that help anchor and open up that suture, as you can see in the picture on the green and the blue. And a lot of times there are little arms that extend onto the teeth that help stabilize, so that way the expansion doesn't happen asymmetrically. The next picture here is going to show just what those mini implants look like in the roof of the mouth. So you can see picture A, where the suture on the x-ray is slightly open, not fully open. Picture B, you show where you're getting true palatal expansion and opening up that mid-palatal suture, which also opens up the floor of the nose, increasing nasal airflow volume. And then on the picture C, you can see where it's fully open. You see the big gap in the front teeth, and you can see the little mini implants in the roof of the mouth that are circled in red. A lot of times now, if you have a really good orthodontist that helps treat this case, you can keep that gap in the front teeth pretty well close to closed during the expansion process. They're finding new techniques and ways of doing that without having to give people these huge gaps during treatment. Okay, so here's a study from 2022 highlighting that expansion in pediatric patients reduced the tonsil and adenoid size by approximately 75 and 50% respectively, thereby improving the airway. And these are huge findings, as no parent I know wants to put their kid through surgery if they don't have to. So if giving them more nasal volume or airflow through the nose by doing expansion and creating more space for their tongue is what helps them establish nasal breathing and decrease the inflammation in the tonsils and adenoids, that's a great alternative option than taking them out surgically. Okay, so it's all a network of things that work in concert to grow the face properly, and it all starts with tongue posture and proper nasal breathing. And I just want to end on one more study here, and it's an older one, but it really does highlight the importance of early nasal breathing. And this study, they took a group of newborn monkeys and had their nasal passages blocked for the first 6 months of life. And at the end of that 6 months, they found that these babies had narrowing dental arches, decreased maxillary arch length, and increased anterior facial height. They grew those longer faces. And so at the end of the 6-month period, they allowed them to breathe through their nose, which led to normalization of muscle discharge and restored adequate oral facial growth. So re-emphasizing the importance of good nasal breathing early on in life, infancy through early childhood. And so with that, I'll turn it over to Dr. Krista.
Thanks, Resa. So what happens when we don't treat the developmental issues early? These are pictures of my adult patients in my practice. And what I see is premolar extractions, acid erosion from GERD, severe wear from bruxism, posterior open bites from sleep appliances, relapsed anterior open bites causing severe wear and fracturing of their posterior teeth, TMJ pain and derangements, and chronic migraines and neck tension. All of these patients on this screen have sleep apnea, and all of these patients have one or a combination of anterior tongue tie, posterior tongue tie, or tongue thrust. And all of these patients have tongue space issues. So these are why I kept going backwards, trying to figure out root causes. And now we're trying to get the word out for more kids and more early development. So the first column here shows the early results of untreated tongue restrictions, and the second column is where my adults with restrictions exist. If we can address muscle dysfunctions, there are a lot of things that can really improve, especially if we address them early. TMJ facial pain and chronic neck tension are things I see in my adult patients with tongue restrictions every day, and snoring and sleep apnea affect health and relationships. The ties between so many chronic health issues and sleep apnea is staggering and really needs to be more of a part of our healthcare screening. It's been long proven that sleep apnea and high blood pressure are linked, and because of this, stroke is one of the biggest risks of sleep apnea. Dementia and Alzheimer's are also really high up there on the list, and when you don't get adequate sleep cycles, your brain has less of a chance to consolidate memory and to remove waste products. And that increases your risk for things like dementia and Alzheimer's. So every system in the body can be negatively impacted by a lack of sleep. And the paradigm is really shifting on this. Sleep apnea is not just the unhealthy fat man anymore. It's becoming increasingly more discoverable in the young, fit female. And with that, upper airway resistance syndrome is a huge problem with our adult patients, and it can actually be a lot more disturbing to sleep than apnea itself because your body is still so much more sensitive and reactive to sleep disturbances than when you move into full sleep apnea. The people that are suffering from this are not your typical sleep disorder patients, like I mentioned earlier. This is where you really see the young, fit female struggling. So they present with jaw joint pain, chronic headaches, and they're really feeling like crap all day. TMD, breathing and sleep disorders, and restricted fascia are super intertwined. And when the jaw is underdeveloped, not only does it decrease the volume of your airway, but it puts excess pressure on the joint as well. So the lower jaw continuously gets forced into a backwards position to try and fit into an underdeveloped upper jaw, and the joints also super influenced by tight fascia under the tongue. Muscles try and compensate for the tight fascia, but then they pull on a delicate joint, and then the bite changes in an attempt to further compensate for the dysfunctional tongues and muscles, resulting in more pressure on the joint. This compensation cycle works for a while as these changes occur, but eventually the whole system fails and you end up with joint disorders and pain. So if you throw in compounding factors like grinding stress and trauma, then you really have a recipe for disaster. We've got a variety of health professionals here today, and I'm sure many of you have been painfully aware in your day-to-day that the body is connected head to toe. So if your jaw and bite are off, it really affects your posture. If your hips are canted, your jaw can be affected. If your fascia is tight, it pulls everything forward and creates compensations. So as we said earlier, we're really committed to lifelong learning, and we really want to reiterate here that we are learning from ENTs, we're learning from physical therapists. We'd love to learn from all of you that are here. Our bodies are all interconnected, and learning doesn't stop with just our profession and our specialty. We need more of you body workers, SLPs, lactation consultants, and others helping us make these connections and really support our patients so they get whole body wellness. This is what collaboration means to us, and we really need you in our community. This slide here is from the Applied Integration Academy, and it really supports why we're here. The AIA is dedicated to teaching clinicians from all walks how to work together and provide patients with quality human performance. So why is a tongue tie release so effective on the rest of the body? The fascia surrounding the tongue is part of the deep front line of fascia, And it goes from the tongue literally all the way down to your toes. And a fascinating result that we see when some patients are able to take a more full, deep breath immediately after a tongue tie release because the deep front line of fascia is so heavily intertwined with the diaphragm. And as adults, we've been developing these adaptations for quite some time, and much of that is blamed on poor posture, but some of it can really be related to that restricted fascia. Weston Price wrote a book that explores how modern diets lacking nutrient density and necessary chewing forces of traditional foods really contribute to physical degeneration. And that degeneration can be seen within a single generation, and it impacts various aspects of physical health, including dental structures, as well as immune function and overall well-being. And my favorite concept recently has been epigenetics. It's a key concept that helps people understand these changes, and it explains how the environment and behaviors really impact how genes express and function without changing the DNA sequence itself. So these changes regulate whether a gene is turned off, turned on, and they can be reversible if you change the environment, causing them to be expressed. I thought I knew what a tongue tie was. I thought it was easy to see 5 years ago, and then I realized I was super wrong. Research is now supporting the existence and significantly higher prevalence of posterior tongue ties or mid-tongue restrictions. And the limitation, that's where the limitation is further back than the tip of the tongue. So the majority of dental and medical professionals don't actually know how to functionally screen for this, so that's why we're here. On the left, you see a severe anterior grade 4 tongue tie that's shown next to a posterior tongue tie or mid-tongue restriction. So that one on the left is super easy to see. The one on the right, much less obvious, right? So if you look at that right photo, you can see the floor of the mouth lifting. So in this case, what we would want to do is the floor of the mouth maneuver and a lingual palatal suction to evaluate the extent of the restriction. And that patient on the right is a patient who suffers from chronic migraines and jaw pain. So it's taken Dr. Resa and I a lot of training to be able to effectively recognize and diagnose these mid-tongue restrictions. And it's not just a visual exam. It's based on symptoms, physical touch, and it requires having the patient perform specific functional movements. So I'm going to touch briefly on some of the diagnostics for those of you who don't spend as much time in the mouth as dental professionals. This screening tool is excellent to keep around and can be found easily online. It's called the Ferris 6. And the Ferris 6 was designed to screen kids for sleep disordered breathing. And then the +4 was added by the Breathe Institute to help screen adults. So running through it real quick, number 1 is mouth breathing versus nasal breathing. Number 2 is the mentalis strain, where they're having trouble closing their lower lip to their upper lip because of the vertical growth pattern. 3 is tonsil size. 4 is tongue restriction from grade 1 to 4. And dental wear is number 5. That is not common in kids. So if you see dental wear, we really should be looking at sleep disorders. Narrow palate is number 6, and then moving on to the +4, you look for tongue scalloping in adults, suggesting that their tongue doesn't fit in between their teeth. You look for tongue overflow, where their tongue can't be suctioned up between their teeth. It flows over because their arches are too narrow. You look at Friedman tongue position, which is the combo of soft palate length and airway tongue creating airway visibility, so airway openness. And finally, palatal flutter, where you make the snoring noise and then you suction your tongue to the roof of your mouth and see if you can still make the snoring noise. If you can, if you're not able to snore, that's a positive palatal flutter. And if you can still make the snore sound, then that's a negative palatal flutter. Another simple test, if you're comfortable in the mouth, is the floor mouth maneuver. And this is where you identify compensations created by the floor of the mouth elevation when someone's lifting their tongue. So if you have compensations, you'll have a better range of motion when you're not holding down the floor of the mouth. You can also easily look for neck compensations. If the muscles of the neck are involved in opening the mouth or lifting the tongue, that's a sign of poor tongue function. So for this maneuver, you don't want to shove your finger down into the floor of the mouth because that can hurt. So you just want to hold it right behind the front teeth, just over the floor of the mouth, and then have them lift their tongue. If you see a depression on the dorsal surface of the tongue, you've got a mid-tongue restriction. And if they can only lift their tongue part of the way, less than they can without a finger in there, then they've got some type of restriction. So 50% of the population may have compensated tongue ties, so you have to be a bit nuanced in your approach to diagnosis and include evaluations of tonsils, adenoids, mouth breathing, and allergies, and a bunch of other things. And know that only some patients may be symptomatic and not all need releases. Dr. Resa and I have learned our surgical technique from Dr. Zaghi at the Breathe Institute, and we both use a CO2 laser for our releases, including on infants. The benefits of laser release versus scissors or scalpel is you have much better bleeding control, you have much better visualization, and then you can make a very precise incision and your depth of cut is super precise. We also suture all of our cases because this allows primary intention healing and less risk of scarring. We want to note that 50% of tongue restrictions have muscle involvement. So myofunctional therapy can really help pull that muscle out of the fascia before surgery so we don't have to be quite so invasive into the muscle. Because that muscle involvement during surgery can create a lot more post-op discomfort. But again, tongue tie is just one piece of the puzzle, and the reason why we're so grateful to each of you for being here, because collaboration is what ensures each piece fits together perfectly so we can help our patients optimally. While tongue tie can be a huge factor, tongue tone and tongue space are critical in order to resolve these issues. If we go around cutting ties in mouths with limited arch space, we can create a whole different set of problems. And this is less crucial in kids because we can still try to get the tongue to do its job of expansion, but it needs to be considered and timed with orthodontics. Tongue tone also is a super important factor because if you release a tongue that's weak, and then you're still not going to get great function. So I'm bringing this slide back for a moment. If the tongue doesn't have enough space to exist with its new freedom after a release, it can make things like sleep apnea worse. There are a lot of ways to approach expansion, like Resa mentioned earlier. You can do traditional ortho and MARPE, and you can do light wear appliances like Alpha and Crozat, or you can move into full jaw surgery. This is a topic all by itself, so we're just going to touch on it because it's critical for optimal results on tongue tie treatment. But tongue tone is where we really rely on myofunctional therapy, and that's another piece that Dr. Resa and I have incorporated due to our affiliation with the Breathe Institute. Myofunctional therapy is key to the success of a tongue tie release, and that's what makes it a functional frenuloplasty, because the patient's able to do specific exercises during the procedure to make it a very precise release and really assess that range of motion at the time of the surgery. So tongue tie release without myofunctional therapy and before and after is significantly less effective, and a large part of why there's still so much controversy around the topic of tongue tie release. The Breathe Institute's published a paper on the safety and efficacy of tongue tie releases if you do it in conjunction with myo. And they're trying to create standards to make sure that this procedure gives patients the benefits that they expect in the majority of cases. And really just give more guidelines around how we get optimal success. Myofunctional therapy is the neurological re-education of muscle function. So when your tongue suddenly has more freedom, it needs to know where to go. Pre-training your tongue to find a new position is critical. And when your tongue has low tone, it won't magically find its way to a new position at the roof of your mouth when it isn't tied down anymore. So that leads to relapse and failed expectations. And if a tongue tie release is done incorrectly or in poor case selection, a tongue tie release can actually increase problems with sleep apnea. But if it's done correctly and conservatively with myo before and after, the risks are super low and the benefits are awesome. I want to touch on this because I've actually seen significant benefits for this in my office. Myofunctional therapy with CPAP users really benefits their tolerance and compliance. So recent studies have demonstrated the efficacy of OMT in reducing snoring, apnea-hypopnea index, and sleep quality. And it also helps reposition the tongue, improve nasal breathing, increase muscle tone in both adults and pediatric OSA patients, sleep apnea patients. And studies have also shown that myofunctional therapy can prevent residual sleep apnea in children after the tonsils and adenoids are removed, and then helps adherence to CPAP treatment. So we're not talking about getting people off of CPAP, we're just talking about helping them to get the best results from it. Then I want to touch on laser tightening of the soft palate. This procedure targets one of the primary culprits behind snoring and upper airway obstruction. That's soft palate tissue laxity. This procedure is designed to complement other interventions for sleep and breathing, such as CPAP and oral appliances. But what it does is it refines the soft palate by promoting collagen production and contraction. And it results in tissue firmness and improved airflow. So the CO2 laser energy is absorbed by the tissue without ablating or cutting it, and there's minimal discomfort and downtime, and the procedure only takes a few minutes, so it allows patients to really resume daily routine shortly after treatment. So back to why this might be important to you guys. We want to work with all of the specialists listed here and more that aren't. So a couple of things you can be looking for your clients that indicate you might have an opportunity for collaboration would be patients with neck tension that isn't resolving, jaw joint pain, chronic headaches, athletes having trouble with nasal breathing, and then of course non-restorative sleep. So our goal here today is to empower all of us to work collaboratively together and to be on the same page, to make sure we're looking at things the same way, diagnosing the same way, because so much is evolving in this field all the time and all of our fields. So the only way we can keep up is together. And if you guys found this informative and helpful, we are more than committed as affiliates of the Breathe Institute to try and do this once every 6 months or so. We are considering an in-person event as well. But this is where we'd love to open it up to you guys and talk about some of the struggles you might be having in discussing these things with patients and connecting dots. And please let us know who else is missing from our collaborative care team so we can get them on the next presentation. I put some QR codes for contact information for you guys. And I'm happy to put my cell phone in the chat too, in case anyone wants to talk about any of this directly. All right, Kimmy, we're ready for any questions if there are any. Otherwise, really appreciate everybody being here.
Awesome job, ladies. That was so good. There was so many nuggets in there. A lot of information trying to, put into 45 minutes is really hard, but I love how broad and comprehensive that was. There are a couple questions. So there were some requests for links to some of the research reference. So I just sort of dropped those links in there as you were referencing those. So I think I got all those in there. I dropped the PDF for the Ferris 6+4 in there as well. Okay, so first question from Jennifer she is asking, do you think that some or many of the adult women who have upper airway resistance syndrome often get diagnosed with mild sleep apnea?
Yes.
Yes, many of them do. Some of them just get ignored though, and that's the problem. They often don't get diagnosed.
Yeah.
They don't even, I don't even think they get diagnosed with mild sleep apnea. They're just told like, well, you don't have sleep apnea.
So therefore, you're fine.
Yeah. A lot of those sleep studies like that they do on people as adults are not, they're not necessarily looking for UARS. They're just studies looking for sleep apnea and whether or not you qualify for a CPAP machine. I have several patients that have told me, they said I have mild sleep apnea, but it's not enough to have a CPAP machine. End of story. And so.
And then it comes down to insurance coverage.
Yeah. Jennifer also has a question about the palatal flutter. So she's asking if you can make the nasal flutter
Mhm.
or the palatal flutter, does that relate to a short anterior posterior space in the palate?
Oh, that's a good question.
Potentially. I think there's a lot of things that can, it could be that they have, potentially, we'd have to look at everything to kind of see. Sorry, Jennifer, it's not a great answer. Because if they don't have good, if they have a mid-tongue restriction and they're not getting good palatal suction, that might be the problem. It may not necessarily be that they have redundancy in the soft palate because the maxilla didn't develop enough. So yeah, but potentially, yes. But it could be multiple things. As you know, it's all, yeah, you know this very well, Jennifer. You're a very good myofunctional therapist, that there's so many things that are affected, and like you fix one thing, but then so many other things were affected by this one thing that now you got to look at those things too. So
Yeah.
yeah.
There's another question that came in. It ended up coming directly to me, but I believe that that's meant for you ladies. Um, from Caitlin, she said, "I'm having a hard time finding medical providers to refer patients to that align with these ideals in Greeley. Can I have a list of trusted providers treating tongue ties and myofunctional therapy?"
Yeah, Resa, you're perfect for Greeley.
Um, so yeah, I'm fairly close to Greeley. I don't have some great ENTs yet, not close to Greeley anyways. There's some in Denver area. Orthodontist, there's a few that I can get you connected with. Dr. Jessica Allen is a periodontist in Greeley. And she has doing a lot of educational hours in sleep airway courses. And she does place the expanders or the mini implants for the MARPE. And she works pretty closely with Dr. Milner, who's an orthodontist in Fort Collins. And Dr. Milner is really great. I met her through the Breathe Institute as well. And she's taken some of Dr. Yoon's courses, who published some of those papers I showed earlier on pediatric sleep breathing disorders. So those are the two right now that I have that are semi-close to what you're talking about. But ENTs are the tough ones. Primary care physicians are also kind of tough.
Yeah.
And pediatricians. Yeah.
And pediatricians, yeah.
But Caitlin could reach out to you directly to kind of keep
Please.
brainstorming.
Yeah, absolutely, yes. I'd love
Awesome.
to chat. Yeah, love to chat more.
Tiffany said, "Very informative. Thank you both for sharing your knowledge and expertise." And Jennifer said, "So good." Neely said, "Thank you." Um, Going back to just a little bit for Jennifer when talking about the palatal flutter, and she said that seeing a lot of like improvement in nasal snoring, but still persisting some for herself and some of her clients. And so trying to kind of apply some of that palatal flutter and the upper airway of the upper airway with her clients. So,
Jennifer, have you had anyone try the the laser soft palate tightening?
yes,
Yes.
she has.
Okay. Okay.
I actually had it done. Dr. Risa did it on me. And yeah, it's super quick and easy and just some topical numbing. And immediately feel a difference. So I immediately felt like more airflow behind my soft palate, like it was almost cooling how much like airflow was passing through there. So that was cool. I wasn't necessarily the best candidate for it, but the opportunity was there, and so I jumped in the chair. Um, and we have a question from someone on an iPhone. We don't know who because the name is not there. But it says, "My sister was just diagnosed with upper airway resistance syndrome based on her recent sleep study. Should her first step be consulting with a myofunctional therapist? She's in Chicago." Ooh, I know who this is.
I know who this is. Uh, yes, I think that that is a great idea. As I was saying at a study club the other night, I think a great first step, if you aren't sure what to do, is to refer to a myofunctional therapist because there is no negative to myofunctional therapy, and they are very good at quarterbacking. So putting all the pieces together, helping like figure out what the patient is actually trying to gain, and then getting them to the right provider.
Mm-hmm. And kind of going back to how Caitlin was saying, trying to connect with those providers, a lot of times the myofunctional therapists are great resources too for having done a lot of what like you two ladies are doing and vetting and trying to find, people on the team. And oftentimes those myofunctional therapists find the amazing providers like you, both of you, and can be good resources too. That was it for the questions. Any more questions, or if anyone wants to unmute and discuss specifics with patients or any other questions about yourselves, because we know that most of us statistically have our own little airway issues that we're fighting the good fight with too.
Just
Dr.
put my
Krista put,
phone in the chat there
mhm.
if
Don't
anyone
mind
needs
it.
it. We are going to put this recording online too. I believe I don't own a YouTube channel yet, but I intend to after this. So we'll put it, and then I can email everybody with a link for where it is.
And Dr. Resa put her number in there as well.
Thank
Well, I would just like to say, because I work with you both and I just have a lot of respect for you, and I love what you're doing and the investment you've made in learning for the benefit of your patients and the people around you is inspiring. And coming together like this just shows how important it is to collaborate and have unity and support each other for the benefit of the patients. And I think it's a really big deal. And Jennifer just put it perfectly that we're so lucky to have the two of you in Colorado. Thank you.
Thanks, everybody.
Thank you.
Thanks for everyone that made it tonight.
So be on the lookout, right? Is that right,
Yep,
for the
be on
next
the
one?
lookout. We're
Yep.
going to do it again, probably do another webinar and hopefully an in-person event, maybe end of the summer, fall.
Perfect. And you already shared your contact information. There's cell phones in the chat. Um, and anybody, like you said, Dr. Krista, anybody who had suggestions for other providers to connect
Yes, please.
them to the two of you so you can include them in your next educational presentation and study clubs and all that fun stuff.
Yep.
Cool.
Grow the network. Grow the village.
Yes. And feed the people.
Feed the people.
Well, I will, unless either of you have anything else, I'll stop the recording.
Okay.
Sounds good.
Okay.